Okay, we're ready to go. First, I want to welcome everyone who is going to be observing and listening to one of the country's major thought leaders on really important issues related to behavioral health. Let me just first tell you a little bit about Dr. Arthur Evans. He's really been involved as a policymaker, a clinical community psychologist, a healthcare innovator, and he's now the CEO of the American Psychological Association. Prior to that, he spent 12 years as commissioner of Philadelphia's Department of Behavioral Health and Intellectual Disability Service. Now, the transformation of the Philadelphia service system, it's just dramatically improved healthcare outcomes, and it saved also taxpayers millions of dollars that the city now has been able to reinvest in other community-based services. And prior to this time, Dr. Evans developed a multidisciplinary private practice in New Haven, Connecticut, where he also served in leadership positions in clinical administration and state government. So he's held faculty appointments at the University of Pennsylvania's Perelman School of Medicine and the Yale University School of Medicine as well. And I first had a chance to meet Dr. Evans at the conference at National Council for Behavioral Health, and he was talking about the transferable technology for real-world problems. And I think what I came away with is Dr. Evans is someone who's really a visionary, always taking a look at what are some of the critical problems that are being experienced in the behavioral health setting, and then thinking about where we need to go, rather than any looking back to the good old days or thinking about some of the current challenges, but those current challenges really in light of future directions. And I was just very excited to hear that Dr. Evans would be joining us to share his perspective on where we need to move as a society in order to improve health outcomes for people. So thank you, Dr. Evans, and we're so looking forward to your perspective. And so I understand that one of the topics that you've been really passionate about is really taking a sort of a population-based focus, right, on population health as a paradigm or framework to kind of guide decisions about how to improve our behavioral health, system. So, you could have chosen to spend your time doing a lot of different things, but you chose to make a point about this and raise people's awareness, a call to action. How come you chose this whole area out of all the things you could have done?
Well, first of all, thank you so much for inviting me. I really loved the times that we've spent together presenting, and I've learned a lot from you, and so I'm very honored that you asked me to do this. I think that population health is an issue that every clinician ought to understand, and certainly every behavioral health clinician ought to understand, every behavioral health administrator and policymaker should understand that perspective. And for two reasons. Number one is because of changes in healthcare and particularly healthcare financing, I think we'll increasingly see population health as a framework for how we look at healthcare delivery in general, and increasingly how we look at healthcare delivery as it relates to behavioral health. But the reason that I'm very invested in population health is that I believe that we will get much better outcomes for the people that we're serving, and we will reach people that we're not currently serving, which are two major challenges that we have in the behavioral health system. And the basic idea with a population health is this. Typically, I'm a psychologist. Most of the people listening are probably trained as clinicians. And we're trained to look at illness, to diagnose that illness, to treat that illness. And as a result of that orientation, we are at any given time dealing with a very small subset of the population, those with a diagnosis and those who are willing and understand how to come out to us and to reach out to us. Well, that leaves a lot of people that we are not intervening with. If you take mental illness, for example, 25% of the population has a mental health diagnosis at any given time. The 75% of the people who don't have a diagnosis cannot get, for the most part, access to healthcare services. Every clinician knows that you have to have a diagnosis if you're going to bill for a healthcare service. So 75% of the population out of the gate are people that we're not paying attention to. And we know as clinicians that many of those people have subclinical issues, And many of those people who are in the 75% today will be in the 25% next year or the year after, but we are not paying attention to them. The other problem is within that 25%, we're only reaching about half the people who have a diagnosis. Only half the people who have a diagnosis are coming into treatment. And so this passive model that we've set up is dealing with a very small set of the population. We're dealing with people once they're in crisis, once they have a diagnosis, and most of the time in most systems around the country, we're dealing with them once they're in crisis. It's not even that people are coming into treatment and getting interventions early in the course of their disorder or their condition. And so one of the observations that I've had as a mental health commissioner and someone who's been responsible for systems is that we are missing most of the people that we need to be interacting with and intervening with. So that's sort of the basic thrust. In a population health approach, what we're doing is we're not only focused on those people who have a diagnosis, but we're looking at the people who are at risk. And in most communities, we know the people who are most at risk. We know that if you've experienced trauma, for example, that you are much more likely to develop a mental health condition. If you come from certain communities within a community or certain neighborhoods within a community, that you're much more likely to have stressors that can lead to mental health challenges. And so in a population approach, you're not only dealing with those people who have a diagnosis, but you're really looking for and reaching out to those people who have greater risk for developing problems, and you're trying to mitigate that risk, or you're trying to intervene at the earliest possible moment. And then the third sort of bucket are people who are relatively healthy. And for mental health practitioners, I think it's really important for us to be thinking about and interacting with people and helping people to stay healthy. We do that from a physical health standpoint. We talk about exercise, we talk about nutrition, we talk about those kinds of things, because we know that if we do those things, we're less likely to become ill. Well, we don't do that when it comes to mental health and behavioral health conditions, and in a population approach, that's another area of focus. And so if you look at those three groups, healthy, risk, and people who have a diagnosis, that encompasses the entire population. And I think increasingly we're going to see healthcare systems move in that direction because it's more costly, we're intervening much earlier, and we have a better shot at getting the kind of outcomes that we want.
Great, great. In many ways, your point is emphasizing really like the idea of prevention. Seems to be in like the kind of the principle behind this, like trying to address folks who are at risk so that they don't enter the category of having much more serious, whether health problems, behavioral health problems. What is it about our system that makes it that we're not designed to begin to address that we pretty much wait for someone to be like pretty sick before we're bringing supports and treatment and resources? Is there something that's ingrained in our system that makes it difficult for us to pay attention to that risk population you mentioned?
That is a very good question, and I think that is at the heart of the challenge that we have in behavioral health care systems. And I talk about, usually when I present, I always talk about the mental models that we have for what we do as clinicians, the mental model that we have for what it means to treat people who have mental health conditions. And the mental model that we have is that one that is based on the medical model of looking at disease and treating disease. And we assume that if we treat disease and disorders, that people are then healthy. Well, we know that that's not the case. We know that the absence of having a health condition does not mean that one is healthy. And one of the philosophical shifts that we're trying to make, particularly in a population way of thinking, is that our goal ought to be having a healthy population, not necessarily having a population that is not ill. Those are not the same. And so part of it is sort of the mental model that we have. We're trained as clinicians to treat illness, when what we really need to be focused on is how do we help ensure and create health in communities. And so that refocusing, that reorientation, I think is a big part of making this shift.
You know what's interesting when I'm listening to you, I'm kind of thinking about how payers see this. You know, how managed care organizations and other payers, which really our system is designed to pay for treatment of illness, right?
It is. It is.
And so, yeah. So can you say a little bit about that? If because I'm thinking about our payment system doesn't seem to set up a contingency to address that, but much more emphasizing let's look at the folks who are going to be the most sick, you know,
Right.
most at risk. And can you,
Right.
yeah, I mean, that's the way I'm kind of seeing
Yeah,
it.
it's counterintuitive, right? Because
Yeah.
in a medical model, what you're doing is you really are trying to devote most of your resources to the people who are the sickest. The problem with that, particularly with mental health, is that what you end up doing is putting all your resources in the crisis basket. And for anyone who's run a crisis system, you know that one of the biggest challenges is what happens when the crisis is over. And when communities don't support the next step, when communities aren't supporting those things that come after the crisis or those things that can prevent the crisis, what it means is that we perpetuate this system of funding and putting our resources and all of our attention on the crisis, and we don't have an opportunity to intervene early, to prevent, and so forth. The reason why I started by saying that it's really important for every clinician and person who works in the field to understand population health is because our current way of financing healthcare, that is a fee-for-service system that only pays for illness, is untenable. The rate of inflation in healthcare is about twice the rate of inflation in the rest of the economy. So healthcare costs have been growing at a really steep curve for decades. And if you look at the proportion of our gross national product that is spent on healthcare, that proportion is growing every day, which means that America cannot be competitive as a country when you take a car and 50% or 25% of the cost of the car is healthcare costs. The country cannot be competitive. And so healthcare payers are looking at how do we bend the cost curve. And the primary way that people see in bending the cost curve is to change the financial incentives. Right now, the financial incentives are on doing more. So if I get paid for treating illness, there is a high financial incentive for me to produce more and more. You do more x-rays, you do more procedures, you do more because that's how you get more income. What payers are understanding is that we have to change that. And to change that, it means putting healthcare providers at financial risk for the cost of healthcare. And essentially what that means is, most people have heard the terms accountable care organizations or health homes. And basically what you're saying is, here's a group of people. Let's say it's a company or it's a community. We're going to give you provider system, healthcare system, University of Pennsylvania healthcare system, any healthcare system. We're going to give you these 100,000 people. Last year, we spent $100 million taking care of their healthcare. We're going to give you the responsibility for treating those people, but we're going to give you the money up front. And if you can take care of those people with the $100 million that we spent last year, anything that you make over that, you can will be profit. Well, when you change now you've changed the financial incentives. I, as a provider, have the money up front through a capitated payment. The incentives for me now are not to produce more, but to produce better. Because if I can keep people healthy, well, intervene early, I'm going to make more money. That's basically the paradigm shift that we're making in healthcare financing. Once you do that, it is real. You have a very strong incentive now to keep people healthy. That was that first group that one of the groups that I talked about. Because if I can keep people healthy, they're not going to incur costs and reduce the profit that I'm able to make. If I can intervene early with that group that's at risk, I can, again, save money, improve outcomes. And clearly, if I can really have effective services for the people who are up front, meaning to not only think about acute care, but what are the services that people need post-care, I'm going to pay a lot more attention to what happens after an acute hospitalization in that system, because I know that if I'm not paying attention to that, a person is more likely to recidivate. So all of the incentives shift, and the idea of understanding the whole population and working with the whole population really becomes really clear why that's important from a clinical care standpoint.
As you were speaking, I spent a lot of years as a clinician working mostly with adults with serious mental illness. And when I think about what was needed to keep some of my, keeping the clients that I work with healthy, I just played one little role in all of that. And it had as much to do with my assisting clients to make use of and to access community resources around housing, around work, around creating, social clubs so that people had a time and a place to feel connected to other people, being in safe communities. It was so much of it was had really not so much to do with my actual treatment interventions, but so much about the person's context, the day-to-day issues. It always felt that if a person didn't have stable and safe housing, they didn't have a time and a place to be with like other people, they didn't have any kind of meaningful way of contributing to the community, and all the other kinds of supports people need, it kind of left me feeling like, wow, I'm not going to get very far. And when I hear you speak, it's kind of like viewing the community has a responsibility to provide the kind of experiences and supports that would make a difference in people's lives along the whole continuum, from people with the most serious problems to those who may be at risk, and those who are likely to be at risk because life is kind of tough at times. Yep. You have to struggle, and then so many people who never get those services at all. And anyway, that's what was reminding me, and I'm thinking of some of the clinicians out there who might be saying to themselves, gee, this makes so much sense because we do need communities, rather than the idea that we can have a circumscribed treatment intervention to try to address issues that are really social problems as much as they, or economic problems as much as they are mental health problems. Your thoughts about that?
Yeah, I couldn't agree more. I mean, it's such, your example is such a good example of the shift that we have to make in the way we think about clinical care. And again, it goes back to the mental model. If the mental model is that I'm a clinician and what I do is I do psychotherapy, well, right, you're pretty limited then in how you help people. But if your perspective and your mental model about what it means to be a clinician is that I'm a mental health professional, I have expertise in understanding mental illness and mental disorders and how to treat them, well, that opens up a whole range of ways that I can interact. It's not just psychotherapy, it's understanding context. We know, for example, that in healthcare in general, healthcare only counts for about 10% of the variance in our health status. So it accounts for a very small part of how healthy we are. What plays a bigger role in our health are things like our social context, our behavior, the environment, biology. We'll spend this year in America something on the order of 3.2 trillion with a T dollars on healthcare this year. We spend more money than anyone in the world by far. If you took the top several countries, you would have to add all of what they're spending to equal what the U.S. spends. But if you look at what our health outcomes, we're at the bottom of industrialized countries in terms of the outcomes. So what we know is that the amount of money that we spend on healthcare is not the determining factor for how healthy a population it is. And I think that because we've ignored those other social determinants of our health, things like housing, things like education, things like social support, we have not gotten the bang for our buck in terms of the healthcare dollar. So in a population approach, health approach, it really is important to pay attention to the community context, to social determinants of health, paying attention to the whole range of things that can help people to be healthy. And in the work that I did in Philadelphia and in Connecticut, we were very intentional about trying to build those things into the system because we knew that those were the things that were ultimately going to get the right outcomes that we were looking for.
Right. Are there other voices out there who see this issue in the same way that you do? Really hopeful signs that perhaps we'll make some progress in this area, or does it seem like you're like a lonely voice out there emphasizing this, or the people who have the voice may not be influencing those who have power, those who can be policymakers, those who can establish billing systems that are likely to encourage this? Just trying to get a sense of, does the future look bright, or does it seem a little bit dim at this point?
Well, I think it's a mixed bag. I think it's a really good question. You're asking some great questions. I'm enjoying this interview, so I hope the audience is as well. But in the early days, I would say about 5, 6, 7 years ago, I didn't see that many people who were out there talking about public health approaches and population health as it relates to mental health and behavioral health. Today, there is a growing group of people, both domestically and internationally, that are beginning to think this way, and we've come together. So in Philadelphia, we had our Healthy Minds Philly sort of initiative. New York City has Thrive, which is they sort of marketed and gotten other people to sort of do that. I was talking just last week with a program in Denver that is using the same kind of population way of thinking about service delivery in Denver. I've talked to colleagues in Ireland and in New Zealand who are embracing that, in Sweden who are embracing this way of thinking. So for me, it's very exciting that more and more people are beginning to think that we need to think this way in terms of mental health and behavioral health service delivery. What I think the challenge will be for us is that what drives what we do as clinicians and providers is based on the financing system. Yeah. And right now, the financing folks, the people who are the payers, are, when they use the term population, you may hear the term population health management. And basically what they're doing is what I call managed care 4.0. And what they're saying is, okay, we're going to stratify the population. They'll stratify the population like I talked about earlier. Who are the sickest folks? Who are the less sick? Who are the healthy folks? But then they will say, we're going to devote all of our resources to the sickest people. And all of that is that's why I call it managed care 4.0. It's just basically another way of describing what we're currently doing, which is putting all of our resources into that group of people who are the sickest. And what we need are more voices that are saying, and financing systems that are really incentivizing people to look across the whole population. So I guess I'm both hopeful because more and more people, there's some folks up at Harvard who are also thinking and talking about a population approach as it relates to behavioral health. So there are more and more people that are doing that, but we really have to put the pressure on our healthcare payers to say it is untenable for us to continue a crisis-oriented system that only seeks to provide services to people who have a diagnosis, because we're missing all of these people who could use our services, use our support. We're not intervening at the earliest possible point, and we're not preventing things that we know we have good technologies to prevent. So it's a mixed bag, and I hope we get more disciples out there who can promote this way of thinking.
Terrific, terrific. Well, we've kind of like ended our very first part of the conversations. and with 30 minutes. And we do have some questions that have
Sure.
come from the audience. And let's see, these seem to be pretty thoughtful questions as well. So one question to you, Dr. Evans, is, are you aware of any currently ongoing or recent public health research similar to like the ACEs study, which for those in the audience who may not know, it really has to do with adverse childhood experiences, which has really generated so much interest over the last like 20 years. Any research that's similar to that, which links health and behavioral health outcomes in the general, population. So is there, it's again another voice, but is that the research folks taking a close look at this so they can demonstrate both the human outcome for people as well as the financial, outcomes associated with taking a more public health perspective?
Yeah, sure. Another great question. As a psychologist, I'm also always interested in supporting my work through research and through science. And I think that, thinking about population health, I think there are different types of evidence that support this approach. One, or some of the things that I talked about earlier, which are the fact that we have lots of people who are in our communities who need our help that we're not reaching because of the way we set up our system. So thinking about those people and how we intervene from them, we have lots of data that show that our systems are not very efficient and effective at reaching people. We also have a lot of data that show that there are ways that we can intervene, if we intervene early, that we can actually change the trajectory of a person's course of illness, particularly, thinking in particularly people who have their first episode of psychosis. Those programs, those early intervention programs for people who have their first episode of psychosis, pretty strong. We have some pretty strong suicide prevention programs. So the notion that we should put more resources into prevention, I think is pretty well established, that if we do that, we can actually, again, change the course of disorders and perhaps prevent really bad outcomes like suicide. We also know that issues like trauma, if we can intervene earlier with people who have experienced trauma, that we can have a very significant impact on people's outcomes. One of the things we were doing in Philadelphia, for example, before I left, was screening children in pediatric settings for trauma. And what we found was about 10% of the children screened positively, and then we were able to connect those children to evidence-based trauma treatments. And for any of your audience who are working in the field, you know that many of the people that we're treating in our addictions programs and in our mental health programs are people who experience early trauma in their life, never addressed, and as a result, they live a life of struggle because that early trauma was never treated. And the fact that we're screening and identifying these children much earlier and treating them, we know that's going to prevent these folks from having, suffering, and frankly, it will also help with costs, because these people will not be experiencing high cost services as a result of getting prevention earlier. So I think that there are multiple ways that we have evidence that using this kind of approach helps people and saves money.
Yeah, it reminded me of, just being aware of some of the research on with maternal support, nurses providing care for women who may be at risk. This is even starting at prenatal kind of like level, to just ensure that there's this nutritional, healthy environment for the developing child, and then providing the kind of support for a few years after that. And the research seems to keep pointing to this makes a big difference, folks looking at longitudinal studies. And then you kind of ask yourself, gee, shouldn't this be something that is just pervasively available, everywhere? Like, as you mentioned, a way of trying to mitigate some of the adversities and stressors that families are under, and then by extension, their children are under. And you would say, wow, that makes perfect sense. The research is there. How come it's not? How come it's not happening in the way that you would think?
Yeah.
We would hope that research actually contributes to policy,
Yeah. Yeah.
and sometimes there's not always that close connection.
Yeah, one of my biggest challenges, and one of the things that I was tried to do very systematically in my role when I was commissioner was to bring the research in and to have our policies and the practices that we were promoting being supported by research. Um, I'm not sure why why it's so hard. It may be that many of the people who are in some of the policymaking positions are not people who are trained in the research and may be unaware. So I think it's really incumbent then for people who have the training, people like yourself, other people who know the research, for us to be out there talking about the research and not only talking about the research, but what are the implications for policy? Because just because people understand the research doesn't necessarily mean they understand how to then take that and transform that into policy. So I think we just need a more folks out there talking about this. And I also think connecting the dots for people is very important. One of the reasons I always talk about population health in the context of healthcare financing is that people will, if people don't make that connection, they will believe that, well, this is something that we can't do because we don't have any way to pay for it. The reality is that, as I mentioned, the financial incentives have to shift. Healthcare payers are moving in that direction. And what I'm hoping is that I'm planting a seed that people will see that when you have an accountable care organization or a health home or any of those kinds of financial arrangements, that this is an opportunity for us to advance a population way of thinking, as opposed to that population health management of only focusing our resources on those who have the most, who are the most ill. So I think we have to try to create a context where people can connect the dots between these philosophies and the policies that we'd like to see enacted.
Right. Here I'm actually sitting at New York University at the McSilver Institute for Poverty Policy and Research, and we're associated with the School of Social Work at NYU, the Silver School of Social Work. And this question that comes from one of members of our audience is really trying to address, as you're talking about planting seeds, right? Some of the earliest seeds is in professional schools, right, that really develop the practitioners. So the question has to do with, do you think the educational systems are emphasizing the significance of population health enough? And in what way do you think a shift in prioritizing population health in education would benefit future practitioners and patients? So those seeds you were talking about, the question really is around, can they be planted where we're beginning to prepare those who are going to be part of this behavioral health care system so that they have an increased awareness of the importance of population health?
Yeah, I do, and I think that the educational systems for all of the mental health, behavioral health practitioners can use that way of thinking. Whenever I've presented at universities doing grand rounds or those kinds of things, it really resonates with people. So I think there's an intuitiveness to thinking this way, and you mentioned that when you were talking about. This kind of makes good sense that we ought to be talking about prevention, early intervention. So I think what's missing, though, is that people need a framework. So I think social work, for example, I'm a psychologist, but I think social work, one of the things that social work does really well is that they understand social determinants, they understand context, they understand the person, environment, interaction. They're doing a lot of the work. People who are trained as social workers are already doing the work. They already have that perspective, but they don't have as a framework to put that work in that really ties all of this together. How does that framework, that way of thinking, relate to people who have most serious illnesses, the people who are at risk, the people who are healthy, and how do I use that way of thinking and working with people across the whole continuum of need? That's what I think is missing. And I think that if we get more of our programs to understand that, I think we can really begin moving this agenda.
Great, great. So this is sort of related to this, both research and education. So what are some innovative or interesting areas within population health for behavioral health patients that young enterprising leaders might want to explore? What might be cutting edge or particular interest to insurance companies or other funders? So I'm sure this is coming from some members of our audience who are, young colleagues
They're all
who are kind of asking themselves, okay, what's going on that I might be able to contribute in some way?
Yeah, well, what I would do if I were a clinician and, sort of seeing this emerging trend, I would really be thinking about how I could play a role in places that have high behavioral health needs that are unmet. Now, that turns out to be almost everywhere, if you
Right.
think about it. And it goes to the point I was making earlier. Um, we have very few train companies today, right? But at turn of the last century, there were like hundreds or dozens of train companies, and those were companies that defined themselves as train companies. Some of them defined themselves as transportation companies. So when the modes of transportation shifted, they shifted because they had defined themselves differently. And I think if I'm a clinician, what I would be thinking is, am I a psychotherapist or am I a mental health professional? If I'm a psychotherapist, that is pretty limiting. If I'm a mental health professional, there are all kinds of ways that I can be using my training, my expertise to help people who have mental health challenges. So what I would be looking for are, and this is one of the things that we did quite a bit in Philadelphia, is to bed in mental health, either experts or expertise within lots of different settings. So in Philadelphia, for example, every family court in Philadelphia had a mental health professional in the court all the time. So when a judge was making a decision about a family, what was going to happen with a child, there was a mental health professional who was assigned to the court who could help the judge make better decisions. We had mental health people embedded in places as diverse as libraries, as certainly schools. A lot of people have schools, but police departments, even people who were interacting with businesses and communities. So I would be thinking about businesses or institutions or systems that had high needs and looking at how I could help those systems and organizations with the mental health challenges that they were dealing with. My experience has been that whenever we reached out to other organizations, other systems, they were glad that we were there. They were happy that we were reaching out to them because they were dealing with that. I mentioned the library. You would think, well, why are the libraries so interested? Well, turns out that a lot of people who have very serious mental illnesses go to libraries, and the staff there don't know how to deal with them. And so by going in, embedding people in urban public libraries, we're actually doing a service to the library patrons and the library system. So I think it's about being creative, and I think most people probably know and can probably guess where the organizations are and the communities that are having the highest need, and think about how you can provide that expertise and be paid for it.
Right.
And a lot of these folks are paid for, by the way.
Right. What's so valuable, because we're coming to the end, what's so valuable about hearing from you, Dr. Evans, is that, this is not an academic exercise for you. You've been in that position as a policymaker when you had to think about how can we actually apply some of these concepts in real life, where it really matters. And you're sharing that perspective, both in terms of having a conceptual understanding, a vision for the future, and how one commissioner, right, in Philadelphia has worked to apply those things in really within that community. So that's what I think is really so special about having you. And I just want to really, again, just thank you for spending your time sharing with us. I think inspiring a lot of folks in the audience out there and beginning to shift the kind of way of looking at one's work, because that's where it begins, is to have a different lens. And you've articulated it so well. And your voice, I think by you lending your voice here, hopefully you'll see others who want to, kind of reflect that same voice in whatever capacity they have, from the young to the old, people as old as I am. Thanks so much for your time. We so appreciate it.
I appreciate you, Tony, and I think that the work you're doing is great, and anything that I can do to help continue to be that voice on these issues. I think most of us come into this field because we want to help people, and this is all about how do we help the most people, how do we have the greatest impact, and I hope more people will embrace this way of thinking. So thank you for this opportunity.
Thank you so much. Take care now.
Okay, thank you. Take care.
Bye-bye.
Bye-bye.